So let's talk about this new module which has been added in the latest Bailey. And in the last 2 years, there have been lots of questions which have been asked. Specifically in the last 1 year, almost every exam has carried a question from daycare surgery, which is why I'm adding this as a separate module. Now, it's a short module, does not have a lot of excitement attached to it, but questions are being asked, so we need to go through it once, okay? Now, I do a lot of daycare cases and patients come in early in the morning. So this was a picture which I clicked in South Africa early in the morning and they get back home by sunset. This was a sunset picture which I clicked in Mauritius. Okay. So that is daycare surgery where they come early to the hospital in the morning and they get back home before sunset or by night. That is daycare surgery. So these definitions are very important for the exam. Outpatient surgery is when the patient is not admitted to a ward facility. Procedure room surgery is when the surgery is done when it does not require full sterile theater facilities. So like I have told you about vacuum assisted breast surgery. So I do a lot of vacuum assisted breast surgeries for fibroadenomas, and majority of the times I do it in my OPD chamber where the patient comes in, I do the procedure and then they leave within an hour or so. So that is a procedure room surgery. Daycare surgery definition has been asked. Daycare or same-day surgery, like I told you, they're admitted early in the morning and discharged within 12 hours. They're discharged within 12 hours. Overnight stay is a 23-hour admission with an early morning discharge. And short stay surgery is admission for up to 72 hours. So we will talk about there are a lot of surgeries which now are being done as daycare procedures. Okay. So the first thing which we need to know, what are the selection criterias for daycare surgery, right? Selection criterias. So medically, we should use the physiological age rather than the chronological age. So we should not see whether the patient is 40, 50 or 60. We should see the physiological age, how functionally active the patient is. ASA status you've already read in anesthesia. Any ASA status over 2 requires careful review. BMI, if the BMI is less than 40, that alone is not a contraindication. In fact, it is said that for surface procedures, if we are doing surface procedures, BMI less than 40 BMI, that is the selection criteria. And if you're doing a laparoscopic surgery, then the BMI less than 38 is applicable or eligible for daycare surgery. Socially, you should have a responsible adult who must be with them for the first 24 hours. And especially for elderly patients who are at a risk of bleeding, home conditions should be suitable and they should be able to contact the hospital and come to the hospital if required. So surgeries up to 2 hours, which are recognized as daycare procedures, and ability to eat and drink within a reasonable time scale. These are the things which we need to take into account when we are scheduling cases, okay, or selecting patients. Let's talk about some more selection criteria which are potential questions for the exam. So you already know about ASA grades, right? We've discussed ASA grades, have been discussed in anesthesia with you. Class 1 is a normal healthy patient and class 2 is a patient with mild systemic disease. 1 and 2 are eligible. 1 and 2 are eligible in a standalone daycare unit. So in a standalone daycare unit, you can operate ASA 1 and 2 patients with no problems. If you want to do a daycare surgery for ASA grade 3, if you want to do daycare surgery, it should be an integrated daycare surgery. It should be an integrated daycare surgery which is attached to a hospital. So just in case it is required, you have all the resources available with you. So 1 and 2 you can do as a standalone unit. 3 you need to do in an integrated daycare unit which is linked with a hospital. Other selection criteria, if you look at blood pressure, if the blood pressure is less than 180 by 100, then the patient is suitable to carry out a procedure. We of course tell them to continue with their antihypertensives. Depending on the type of antihypertensives, the anesthetist will tell them to take the medication. If it is a diabetes mellitus patient, if the HbA1c is less than 8.5, then the patient is suitable for daycare surgery. These patients, of course, we try to take them up early in the case so that they don't have to be fasting for a very long period, and they are told to miss their morning dose, miss their morning dose of OHA, morning dose of oral hypoglycemic agent. We tell them to miss that in the morning. The body mass index criteria, as I've already told you, if the BMI is less than 40 kg per meter square, we can do surface procedures as daycare procedures, and less than 38 kg per meter square, we can do laparoscopic procedures as well. Another thing which is written in Bailey, epilepsy, if it is well controlled on medications, if it is well controlled, it is not a contraindication. So epilepsy is not a contraindication, and they should be told to continue their medicine, and there should be a responsible adult who should accompany them, who can drive them back to home. So these are the selection criteria which we take into account when we are going to post a patient for daycare surgery. Now, scheduling of the cases. Now, if it is a dedicated daycare center, if it is a dedicated daycare unit, then cases are scheduled one after the other so they can be discharged on time. But if it is a mixed list, what does it mean by a mixed list? Mixed list means where there are daycare cases also, short stay cases also, and long cases also, right? So if it's a mixed list, then daycare cases should be done first. Daycare cases should be posted early. So that they can be discharged on time. So like I do a lot of daycare cases, a lot of my breast surgery cases are daycare cases. If they're covered in insurance, then they have to stay for 24 hours. Otherwise, I do them as daycare. So I start my theater by 7:30, 7:45, right? By 7:30, 7:45, I give my incision for the first case, and I try to finish all my daycare cases by 10:30, 11, so that they can be discharged by around 5 or 6, we can send them home, right? So that is how we schedule the cases. Of course, I've told you in scheduling that if you have a patient who has comorbidities like diabetes, hypertension, you'll try to schedule them early so that they don't have to fast for a longer period of time. Now, anesthesia and analgesia are very important in patients with daycare surgery. So we use total intravenous anesthesia is used wherever applicable. This is TIVA, total intravenous anesthesia, and this is with propofol. So propofol is used, and this reduces the post-operative nausea and vomiting. This question has been asked in one of the super specialty exams, that just by using propofol or total intravenous anesthesia, the risk of post-operative nausea and vomiting is less in these patients. Also, analgesia in these patients, we give infiltration after surgery. So whenever I finish my surgery, I infiltrate bupivacaine, which is a long-acting local anesthetic. So at least for a few hours, the patient does not have pain. So adequate analgesia should be provided, and anesthesia should be in such a way so that there is quick recovery and the patient can be discharged. I will talk about the ERAS protocols. What is ERAS? ERAS is Enhanced Recovery After Surgery. ERAS is Enhanced Recovery After Surgery. Protocols, which I'll tell you towards the end of this module. So those factors are also taken into account when we are dealing with daycare cases, so we can have a quick turnover. Now, whenever we do any procedure, of course, there can be complications, and that is something which we need to monitor very closely in patients who are undergoing daycare procedures. So the postoperative complications which can be there are, you can have hemorrhage. Now, we have already spoken about the types of hemorrhage in shock. We know that there can be primary hemorrhage which can occur during surgery. There is reactionary hemorrhage which can occur 4 to 24 hours following surgery, and this usually occurs due to dislodgement of clot. dislodgement of clot, or slippage of ligature, or slippage of knot. I will tell you later on in the modules that if you use a granny's knot is a slip knot that can slip out easily and the patient can have reactionary hemorrhage. And one more thing which I want to tell you here is that before we close a case, like supposing I have a patient whom I'm operating on, before I start suturing the skin, I always ask the anesthetist what was the baseline BP at induction. Right? Why? Because supposing the baseline BP at induction was 140 by 90. But the anesthetist will maintain the BP at a lower level while I'm doing surgery. So the BP they maintain at say 120 by 70. But that is not the normal BP for this patient. Now, if I close at that BP and after reversal the BP shoots up, then there can be vessels which can open up and they can bleed. So which is why before I close a case, I always make sure that the BP is close to the baseline BP so that we don't miss any bleeding. And you can have secondary hemorrhage as well. Secondary hemorrhage is after a few days. Secondary hemorrhage is after a few days, and this is usually due to infection. So in patients who've undergone daycare surgery, it is very important for us to monitor for reactionary hemorrhage, right? It is very important for us to monitor for reactionary hemorrhage. And for open cases, we can of course monitor with the soakage of the dressing. In the drains, we can monitor. But the problem occurs in laparoscopic surgery where there can be covert hemorrhage, where we don't see the hemorrhage and there can be covert hemorrhage. And that is something which we need to actively monitor. And that is why at the time of discharge of these daycare patients, we give them clear instructions that, if you have dizziness, if you feel lightheaded, if, you have features of you're about to faint, you should immediately rush back to the hospital. Other problems are post-operative nausea and vomiting. This is also a very common complication which can occur following daycare surgery. And to assess post-operative nausea and vomiting, we have the Apfel score. This has also been asked in one of the exams. The term has been asked. The Apfel score is used for predicting nausea and vomiting. Again, you don't need to know the details of this score. You should just know that Apfel score is used. And that is why we avoid agents like morphine, which can give rise to postoperative nausea and vomiting. And also I told you we use total intravenous anesthesia. We use total intravenous anesthesia to reduce postoperative nausea and vomiting. Also towards the end of the case, long-acting antiemetic should be given in these patients. Long-acting antiemetic should be given in these patients. Okay, I will continue with the complications, but I just want to tell you a story here. This is a picture which I clicked in South Africa of whale watching, and every time I talk about post-operative nausea, vomiting, I always remember this day because me, Dr. Ila, and my sister-in-law, we were in a small boat and we had gone whale watching. We were of course there with 6 other people, and the waves were the current was so strong that the boat was moving around, right? And initially Dr. Ila started vomiting, then my sister-in-law started vomiting, and by the end of it, as soon as the trip was about to get over, I also vomited. And, there was a bucket which was kept there and I was busy passing the bucket to both of them. And eventually I also had to use the bucket. So that's what I remember whenever I talk about post-operative nausea and vomiting. The other complication, of course, is pain. And to reduce the pain, I have told you that we use infiltration of bupivacaine, which is a long-acting local anesthetic, and we give adequate analgesics to patients as well. So these are some of the complications which you should know about in daycare surgery. Now, what are the surgeries which can be done as daycare procedures? So you just need to know an idea of these surgeries as well. So abdominal surgeries, if you have basic treatment of anal lesions, hemorrhoidectomies, so stapler hemorrhoidectomy, which I'll talk about later, is done. Inguinal hernias can be done. Laparoscopic cholecystectomy is being routinely done as daycare procedures where patient comes in the morning and they go back. Pilonidal sinus surgeries are also being done. Breast surgeries, I told you, majority of the breast surgeries are daycare procedures, barring cancer surgeries where we keep the patient for a single day. Most of the other surgeries are daycare procedures. Genitourinary surgeries, TURP, orchidectomies, circumcision, excision of hydrocele, varicocele, and epididymis. Okay, so with orchidectomy, let me tell you one more instance, and this was in Safdarjung Hospital. There was a boy whom I remember was he used to work at McDonald's, and he had a testicular tumor. So he was called in for an orchidectomy as a daycare procedure. And I remember it was our final year postgraduate who did that procedure as an independent case. And our professor was, of course, assisting, but he was just standing there. The patient was shifted to the recovery room. And fortunately, we had one of the most dedicated nurses there posted in the recovery room that day. And she diligently noted the vitals, and she noticed that in the recovery room itself, there was a drop in the vital signs. And eventually, within 15 minutes, this patient went into shock. And we had to re-explore the patient, and he had a huge collection in the retroperitoneum because the ligature had slipped. Okay, so like I told you, there can be covert hemorrhage. Hemorrhage is one of the complications, which is why very good monitoring is required if you're dealing with daycare cases. Some of the orthopedic surgeries and vascular surgeries like varicose vein procedures can also be done as daycare procedures. Now, when do we know that the patient is fit to be discharged? This is another thing which has been asked in various exams, including your super specialty exams as well. So what are the discharge criteria which have been written in Bailey, and you should know about them? The vitals should be stable for at least 1 hour. Patient should be oriented to time, place, and person. There should be adequate pain control to oral analgesia. So this is very important. With the supply of oral analgesia, not IV, pain control should be with oral analgesia. Patient should be able to dress and walk where appropriate. There should be minimal nausea and vomiting and dizziness, very important. Has taken oral fluids. Okay, minimal soakage. Has passed urine. There is a responsible adult present with them, can read verbal and written instructions, and knows when to come back when appropriate. Okay, so these are some of the criteria which you should remember, especially the ones which I'm highlighting. So vital stable, oriented to time, place, and person, adequate pain control, minimal nausea, has taken oral fluids, minimal bleeding or wound discharge. These are some of the criteria which you should remember. Only when these criteria are met do we discharge a daycare patient. Okay. Now, like I told you that the number of daycare cases are increasing everywhere, which is why we want that there is enhanced recovery after surgery. Now, this is not only being used in daycare surgeries, it is being used otherwise as well. So, first of all, you should know the full form. This has been asked in the All India exam. ERAS stands for Enhanced Recovery After Surgery Protocols. And there are certain interventions before surgery, during surgery, and after surgery which are taken so that the patient can be made fit quickly and discharged quickly. So preoperatively, patient counseling and should be done. Patient should be told what they are going to undergo, because it has been seen that if the patient knows and the expectations are set correctly, their mental attitude towards the procedure is much better. We should avoid mechanical bowel preparation. Avoid mechanical bowel preparation because it has been seen that those patients who undergo mechanical bowel preparation in the form of enemas or PEGLEC, they can suffer from metabolic abnormalities or dehydration, right? So avoid mechanical bowel preparation. A revolutionary change has been that solids can be given up to 6 hours prior to surgery. This I'm sure Dr. Chaitanya has also covered with you. And clear liquids and carbohydrate rich liquids, carbohydrate loading can be done, and clear liquids can be given up to 2 hours prior to surgery. So these are two very important things. We consider painkillers and anxiolytics prior to surgery. Intraoperatively, minimally invasive surgery, laparoscopic surgery should be done so that the cuts are less, pain is less, faster recovery. I've already told you that long-acting bupivacaine should be used. We keep the patient warm, and prophylaxis for nausea and vomiting should be given. This I've already told you previously. Painkillers post-operatively, you should give adequate painkillers. Opioids only for breakthrough pain, because opioids can increase post-operative nausea and vomiting. Early food should be given. So within 4 hours, sips of liquid should be started if it is applicable in that surgery. Like for my breast surgeries, the patient in 3 to 4 hours, they're taking liquids. And once they tolerate liquids, we give them some semi-solids to eat as well. Right? Soft diet and then semi-solids. Regular diet within 24 hours. We discontinue IV fluids within 24 hours. Ambulate within 24 hours. We avoid drains, right? Avoid drains. Avoid nasogastric tubes wherever possible. So all these are criterias which are known as ERAS criterias, and there have been questions which have been asked regarding the ERAS protocols as well. So that brings us to the end of this module on daycare surgery. It's a short module, but I've told you some very important points which are being asked in exams. So you should definitely go through this module, right? This module is not so relevant for final year students. Up till now, I haven't seen any university examiners asking questions from daycare surgery, nor is it asked in your Viva as well. So this is predominantly from the MCQ point of view. Before we end this module, let's quickly do some MCQs. Overnight stay is 23-hour admission with early morning discharge. This we've discussed. Which of the following is not a discharge criteria used in daycare surgery? This question has been asked. Minimal wound discharge, minimal nausea, accepting oral liquids, adequate pain control with IV analgesics. No, it is with oral analgesics. So this is wrong. All of the following are true about daycare surgery except in a mixed list, daycare surgeries should be scheduled first. Yes, I told you because you want to discharge them early. Epilepsy is not a contraindication provided it is controlled. This is true. Total intravenous anesthesia with propofol has increased risk of post-operative nausea and vomiting. No, it has reduced the risk of post-operative nausea and vomiting. Major procedures should be scheduled early in the morning. That is correct. Nowadays in daycare surgeries, more proactive approach is being used to prevent unnecessary surgical stress. Which of the following steps is not included? So ERAS, I told you, early ambulation is there, pain control is there, minimally access techniques are there. 8 hours of fasting, no. 6 hours of solid fasting is enough. And 2 hours, up till 2 hours prior, clear liquids can be given as well. APFL score, I told you, is for post-operative nausea and vomiting. This we've discussed. In units adept to doing daycare surgery, body mass index is acceptable for laparoscopic procedures. So 38 is the BMI till which we can do laparoscopic procedures, and 40 is the BMI for surface procedures. All of the following are components of ERAS, that is enhanced recovery after surgery, except use of NG tube is encouraged. No. Epidural analgesics are encouraged. Correct. Avoiding fat containing foods for 8 hours. True. Carbohydrate rich liquids can be given till 2 hours before surgery. True. This is also true. Okay. So these MCQs are directly lines which I've taken from Bailey and made MCQs. So you should know about them. This is a very important module for future exams. So please go through it at 2x speed. Do revise this module. Thank you.